Cardiovascular disease strikes in every nation around the world. From sudden cardiac arrest to the disabling effects of ACLS and stroke, cardiovascular disease remains a leading cause of death and disability in many parts of the world. Understanding and activating the systems of care developed by the American Heart Association can help improve survival rates and may even prevent cardiac arrest. You play a pivotal role in providing high-quality cardiovascular care. What you do matters. What you learn can save lives. Welcome to the American Heart Association's Advanced Cardiovascular Life Support Update course. In this science overview video, you'll be presented with the most recent recommendations on cardiovascular care based on the latest scientific studies. In the next few minutes, we'll outline the changes in the 2010 American Heart Association guidelines for emergency cardiovascular care and continue to emphasize some of the core recommendations from the 2005 guidelines. These guidelines were produced after an exhaustive review of thousands of peer-reviewed publications. We'll approach these changes systematically by first reviewing changes to basic life support, or BLS guidelines, followed by the newest recommendations for advanced cardiovascular life support, or ACLS guidelines. The steps in the BLS survey for healthcare providers have changed. Instead of the familiar steps of A, B, C, D, where clearing the airway and breathing come before chest compressions now take priority for the unresponsive arrest patient. The guidelines now recommend delivering chest compressions first, before clearing the airway and giving ventilations. The American Heart Association removed look, listen, and feel for breathing and giving 2 rescue breaths from the initial assessment entirely. So, the BLS survey now includes these 4 steps. Step 1. Check for responsiveness. Tap and shout, "Are you all right?" and scan the chest for movement. Step 2. Activate the emergency response system and get an AED. Step 3. Circulation. Check the carotid pulse. If you find a pulse, support the patient with rescue breathing once every 5 to 6 seconds. If you cannot feel a pulse within 10 seconds, initiate CPR by giving 30 chest compressions followed by 2 ventilations. Do not spend more than 10 seconds checking for a pulse. Step 4. Defibrillation. As soon as possible, connect an AED or defibrillator and, if indicated, deliver a shock. Why was it necessary to change these familiar steps? The majority of adult sudden cardiac arrest patients have VF or pulseless VT rhythm. The heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillations. The ABCD sequence often delayed chest compressions as the healthcare provider tried to open the airway and deliver ventilations. By changing the sequence and giving chest compressions first, more patients may achieve return of spontaneous circulation, or ROSC. However, there are cases where healthcare providers should tailor the sequence of rescue actions to fit the most likely cause of arrest. For example, in the case of a drowning victim or other instances where hypoxia is the likely cause of the cardiac arrest, the priority would be to provide rescue breathing. High-quality chest compressions were emphasized in the 2005 guidelines. The American Heart Association continues to place a strong emphasis on high-quality CPR. This is indicated by a rate of at least 100 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, switching rescuers every 2 minutes, minimizing interruptions in compressions, and avoiding hyperventilation. The recommendations continue in the new guidelines because scientific studies continue to link high-quality CPR to ROSC. High-quality chest compressions maintain blood flow to vital organs, especially the heart and brain. One way to measure the effectiveness of chest compressions is with coronary perfusion pressure. Coronary perfusion pressure is the difference between the pressure in the aorta at the end of ventricular relaxation, or the aortic end diastolic pressure, and the pressure in the right atrium, or the right atrial end diastolic pressure at the same time. The higher the coronary perfusion pressure during CPR, the better the survival rate for the patients. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the brain and heart. When rescuers interrupt chest compressions, perfusion pressure falls dramatically and remains very low until they resume compressions. Since coronary perfusion pressure measurements are not readily available during a resuscitation attempt, rescuers can monitor CPR quality with waveform capnography and intra-arterial relaxation pressure. We will discuss the details of waveform capnography in a minute.
A reading of less than 10 millimeters of mercury will not achieve ROSC. For intra-arterial relaxation pressures, a reading of less than 20 millimeters of mercury indicates ineffective compressions.
To perform high-quality chest compressions, rescuers should push hard and push fast. Push hard means that the rescuer should compress the chest at least 2 inches. This is a change from the previous guidelines that suggested a compression depth between 1.5 and 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to deliver at least 100 compressions per minute. Scientific studies show that the rate of chest compressions is directly linked to ROSC and neurological survival. It can be difficult to maintain such a vigorous pace, which is why the American Heart Association recommends that rescuers switch roles after 2 minutes or 5 cycles of 30 compressions and 2 ventilations. Another characteristic of high-quality CPR is minimal interruption in chest compressions. Studies demonstrate that even healthcare providers interrupt compressions far too often or for too long, in some cases spending 25 to 50% of a code without delivering chest compressions. The American Heart Association cautions providers against spending more than 10 seconds checking for a pulse or assessing the patient. Finally, high-quality CPR must avoid hyperventilating the patient. For arrest patients, appropriate tidal volume should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a bag squeeze of an adult ventilation bag. Hyperventilation can not only cause gastric inflation and resulting complications, but excessive ventilation increases intrathoracic pressure, decreases venous return to the heart, and lowers cardiac output and survival. In terms of defibrillation, there are no major changes in the guidelines. The emphasis remains on a fluid integration of defibrillation within high-quality CPR. Rescuers should start chest compressions and use the AED as soon as possible for the best patient outcomes. The AHA still recommends the one-shock protocol for VF and pulseless VT. Let's review the changes to the BLS survey, which is now made up of these 4 steps. Check the patient for responsiveness. Activate the emergency response system and get an AED, then check the carotid pulse. If you cannot detect a pulse within 10 seconds, start chest compressions immediately. Give 30 chest compressions followed by 2 ventilations. If indicated, deliver a shock with an AED or defibrillator. Also emphasized in the new guidelines are minimizing pulse checks, limiting interruptions in chest compressions to 10 seconds, delivering high-quality chest compressions in rapid defibrillation, switching rescuers every 2 minutes to avoid fatigue, and avoiding hyperventilation. BLS is the foundation for ACLS. The better these steps are performed, the better the patient's chance of survival. There are 4 general categories of changes to the Advanced Cardiovascular Life Support Guidelines. Changes to the cardiac arrest algorithm, the addition of a new post-cardiac arrest care algorithm, updated recommendations for airway management, and synchronized cardioversion. Let's start by reviewing changes to the cardiac arrest algorithm. The 2010 guidelines simplify the algorithm. In addition, the AHA created a circular cardiac arrest algorithm to emphasize the interventions that have the greatest impact on outcome. The priority is the 2-minute continuous cycle of high-quality CPR and defibrillation. All advanced interventions, including IV access, drug delivery, and advanced airways, should not interrupt the continuous circle of chest compressions and shocks. Rather, they should be performed or administered strategically after the brief pause for defibrillation. This cycle continues until ROSC, when healthcare providers will initiate post-cardiac arrest care protocols. Within the cardiac arrest algorithm, there are several drug administration recommendations for both cardiac arrest and non-arrest patients. There are no changes to the 2005 recommendations for the use of vasopressors and antiarrhythmics for patients suffering from cardiac arrest. During cardiac arrest, rescuers should administer a vasopressor every 3 to 5 minutes. Epinephrine is acceptable, although vasopressin can replace the first or second dose of epinephrine. Rescuers should administer amiodarone for refractory VF and VT. However, the AHA no longer recommends atropine for routine use in managing PEA or asystole. Studies show that the drug is unlikely to have a therapeutic benefit. For the treatment of undifferentiated wide complex tachycardia, ACLS providers can consider adenosine in the initial treatment when the rhythm is regular. For symptomatic bradycardia, the AHA now recommends IV infusion of chronotropic agents as an equally effective alternative to external transcutaneous pacing, when atropine is ineffective. Although defibrillation recommendations did not change, there are new recommendations for synchronized cardioversion. For cardioversion of atrial fibrillation, the guidelines recommend that the initial biphasic energy dose is between 120 and 200 joules. The guidelines now clearly recommend cardioversion for monomorphic VT. In those cases, the initial energy dose is 100 joules.